What is it that we wanted her to do, Christy? What was it again? Oh.
I mean, could use help if I give her the spreadsheet on dropping those into the template. You want to connect me with her? I can work with her on that.
Hey, Dr. Nario.
Hey, are we good to go?
You should be here. I got Kevin's here with me.
Oh, really? You guys are nitpicking?
The staff is in.
We're in.
The
Yeah.
staff, the whole team?
Need some penicillin to get rid of it.
What is that a disease?
What, staph?
Yeah.
No, Staph aureus.
It's not communicable, right?
Let's hope not. Right? You know that
But,
it's a WC Fields saying I wouldn't want to be part of any I wouldn't want to be part of any group that would have me as a member. Right?
Hey, I got another last minute sponsor.
Oh,
So
how about getting some last minute customers?
Oh,
Sponsors we have.
I thought we got 50 already in the house, as Kevin said.
Why
So
doesn't
we can't
the revenues commensurate with the
50, we can't fit any more if we add, I guess, anticipate extra like 60, right?
Counting speakers, we're probably going to have at least.
Yeah, well, they're not all going to be there at the same time, and then we have the slaggards
The one that you rejected.
who aren't going to be there at all. The one we rejected, you didn't count her, right?
We rejected a couple. Which
What? We rejected
The
the
mushroom
standard.
lady. The mushroom lady was the one.
Dr. Mario on that call. You would have found that entertaining, I think.
Dr. Nario would have aged 10 years in that 10.
Hey, I would have jumped in.
I aged 5 years on that 20-minute call.
We're not having it.
It's mushrooms. I'll buy in probably.
Yeah, well, and not only is she where's Burgess? Not only is she a purveyor of mushrooms, she set up a church. She has a church, the Church of Latter Day Lion's Bane. Latter Day Lion's Bane.
I thought it was Latter-day Saints, but
Oh,
sure.
it's Latter Day Lion's Mane, which is one of the main brain mushrooms.
Sure. That works. So we have a lot of online peeps. That's what you're saying.
Get an online count? How many we have?
A lot more on that.
I mean, that's always the pattern these days. So,
But we're still going for 50, right? I'm gonna call the Great Four Gardens and give them the number.
I feel like that's the number. Yeah, I did the count, and then we added Marissa at the hotel said she allocates her about 5%, which we could probably apply, give or take, to Critical Guards. But yeah, 50. Yeah. What about sponsors? Do we feed them? I guess we do, huh?
they're the ones who are paying the most.
Yeah.
Yeah,
We don't
sponsors.
want them dropping over,
Stay away from the food.
Yeah. Yeah, you're not
So
allowed.
we're sticking with 50, right?
Stick with 50.
Yeah.
Okay. I want to make sure.
It's actually not too bad for a little place in Reno, halfway between Christmas and A4M.
Oh yeah. Well, even though there's excess food, we'll take it home.
You have enough food to you put it in the freezer, you could probably eat for a year.
Well, it's winter, so we need to stock up on food anyway. I like the beers, right?
Yeah.
So
Well, I should run these more often. I've lost 15 pounds since we started this little project, and I'm not dieting at all.
the stress of it all.
I think
That's fine.
I think I might have muted you. So
Oh,
I can't keep leaning on Stefan. Our speaker dropped out this.
well, your topic's pretty good. The Coimbra.
Yeah, you know about it?
Yeah, I've heard of this.
Okay, I hadn't. We learned about it at AMMG, and
Yeah,
I thought it was pretty neat. So,
it's a good thing you're not presenting this to conventional docs. You're gonna for sure drop their pants when they hear
uh,
this.
well, we relish that. We
Dropping pants.
we live to have a real doctor's hair set on fire. That's otherwise,
Sure.
why get out of bed?
Huh. We'll take it, right?
Exactly. So, right? Why even bother?
Yep. Why even bother?
Right? We don't want to get out of there's no point. There'd be no point to it. So,
But
really?
Oh,
The food's expensive,
I know it is, but
We'll just have the last stragglers. We'll just have them. We'll do a Hunger Games. Let them scrap for it. We'll throw. There's enough food for three people, and there's eight of you. This is what you get for signing up late.
we haven't done remember we're going to send emails to the presenters for that 5 minute interview because I thought Kevin and Steve will talk about that.
Did we do the? We're not gonna do the interviews.
no, we can do it. I didn't send the emails out though. What do you want to say in that? I'll do that.
Yeah, remember I think Steve was kind of thinking
No,
that
it's
we're
okay.
going to huddle up one time of the day to huddle up everyone. I don't know where that conversation went.
I just want to make sure that you guys have your expectations set with, how many, who you want to offer that to, that sort of thing. Just make sure we can capture everyone you guys want really. What were you thinking?
It was Dr. Bill. I think Dr. Bill, you said they can use it for their advertising, speakers.
Well,
The speakers? Yeah.
I've done them before, and they send you your clip, and you can put it on your website. You can use it for you can use it. You can put it on YouTube. You can use it as an average a testimonial for yourself, that kind of thing.
Hmm.
Yeah.
They're nice, but a month later, nobody remembers them.
Yeah, but again, still, so we're gonna send out emails for them to
Yeah.
see this.
Give me a little guidance. What should I offer them? I just don't want to over offer, I guess. Just let them know that we're going to do a 5 minute feature, and we'll squeeze that in between talks, and they can promote
their practice.
their practice. Sure.
It's what they can't say when they're up on the podium.
Okay. Got it. Send you guys.
So yeah, so you're Kevin, you're just gonna make that letter and said, I mean email.
Hey, Melvin, or someone who is internet inclined here, my Zoom opens. I logged in before you brought me in, and it's small, rectangular, and I exited, relogged in, and I still have a narrow 2-inch wide Zoom window instead of the whole screen.
Good timing. You mentioned that Kevin's there, our tech expert.
Is that the video?
Let's see.
There's no arrows to make it bigger. If there's any arrows, it makes it small.
Shoot. Let me look on my laptop. I've seen that before.
At the bottom where it says video, you don't have anything like that?
It says stop video. I have something that says more. And when I look through that, it really does not show anything to make it full screen.
Setting in the general settings at all?
I feel like that's just, it's very not obvious sort of situation. You know what he's talking about.
All right, we'll try and figure it out for you, Adam.
Well, if none of you have it, it's my problem. I gotta, I don't know, turn my iPad off and reload it and, see if it comes back.
Yeah, sometimes in the when in the general thing when with video, sometimes I don't know, you play around with it and you hit a button and don't know. That's what happens, that kind of thing.
Yeah, no, I get it.
So
Um, uh, General settings, I guess. I don't know.
okay.
Were you having the same problem I was? I only had a 2-inch screen. I had to sign off and re-sign in.
Dr. Bill, you know who's a good crowd for this Coimbra protocol? The Philippine group. They actually had a workshop about this.
Hmm.
I saw it on there. So you're gonna get
Oh,
a
I got a full screen now. I don't know why.
Right.
I have no idea.
Well, Kevin over here did something and something dinged. So
that's
Oh,
why we got
we're going to
Kevin.
give him credit.
That's why we have Kevin on this team.
That's right. We'd make you an honorary doctor here, but then that would ruin your life. So,
Hey, you get free steak dinners for Testo.
yeah, yeah. So, anybody who's a prescriber that's coming to Reno tomorrow, let me know. We have a dinner with the company that makes T-Lando, which is a oral testosterone on deck in '08 at Bricks. It's right near the hotel, so it's at 6:30. So I have to send in reservations. So we tried to get Dr. Siegel in, and they sort of said no. Our veterinarian. But
I'd love to go.
uh,
I'd love
um,
to go.
okay, so I'm sure I have your I'm sure I have your
Let's see.
contact, right, Jeanette?
You should. Let me put my camera back on so you can see me. Short video.
Okay. All right. When we're done, I'll get in touch with them unless, well, maybe I can do it during Dr. Nario's uh
Yep.
tip of the week, since
Okay.
our speaker this week, unfortunately on Sunday, um let me know that he couldn't make it. So not that I had nothing else to do, since the conference is on Thursday. So I'm going to be giving the talk tonight. Um, and it's so we'll let Dr. Nario. It's a little bit after 5. And anybody else in the Reno area or going to be around tomorrow around 6:30?
Yeah, Dr. B, I think I would go too.
Okay, okay, so I can't promise anything, but
Yep.
I will try. All right,
Okay.
so Dr. Nario, if you can talk for about at least 5 minutes,
I
uh,
can
I'll,
talk longer. No, I'm kidding.
okay. All right, I'm gonna try and get.
All right. Okay. So, so again, we're going to talk about our tip of the week today. And today we're covering a molecule that's basically the fantasy of every patient who asks, Doc, is there a way to get the benefits of exercise without actually exercising? Well, scientists at St. Louis University said, hold my pipette and create SLUPP332, an experimental compound that activates the estrogen-related receptors, so ERR alpha, beta, and gamma. So don't worry, despite the name, it's not estrogen related, no hot flashes, no drama, no uterus, no involvement. And again, what is it? SLUPP332 is an exercise mimetic. It activates the ERR receptors, which regulate mitochondrial biogenesis, oxidative metabolism, fat oxidation, ATP production, muscle endurance genes. So think of ERR receptors as the master electrical panel of mitochondrial function, and it doesn't just flip a switch, it turns the whole house back on. So from an anti-aging standpoint, this targets the holy trinity of decline, meaning reduced mitochondrial density, reduced VO2 max, and reduced metabolic flexibility. If GLP-1 drugs manage appetite and peptides help repair tissue, SLU aims straight for cellular energy capacity, the part we've never been able to actually be effective using our drugs. And currently, the research of this is still in the process. Why am I bringing this up? The reason why is because I'm seeing patients who are using this, and this was also mentioned in the fellowship, that as we expound our practices, we need to be familiar with new therapies out there that our patients that are using. So we need to be updated. The one who I've noticed using this are actually bodybuilders. So again, the rule in medicine, the moment a molecule burns fat, bodybuilders get it before researchers do. So anecdotally, it's the wild west when you hear it on online forums, and they have different doses, and they call it cardio in a capsule. So they stack it with their peptides, with their estrogen blockers. So claiming they don't need pre-workout anymore when they use this. So it kind of was triggered also by a patient of mine who actually was using this and need to do a little bit more research. Again, we cannot advise on this as clinicians, but it is something that we need to look out for the future, because they are actually currently doing preclinical trials as of now. And in the trials, the results have been tremendous. Fat loss, even on a high-fat diet, increased energy expenditure. They burn fat like they're training for a tiny marathon. More oxidative muscle fibers, basically turning couch mouses into cardio mouses in the study. Better insulin sensitivity, reduced liver fat and inflammation, and improved mitochondrial density. Again, zero estrogenic effects, even though I mentioned ERR receptors here. And again, very important for you to understand. In the longevity scene, it is something that, again, it's a mitochondrial amplifier, not a stimulant, not a peptide, not a hormone. It's a true cellular energy upregulator. So again, it's called, in the market, when you hear it from your patients, it's called SLUP, SLUPP, but the number is 332. Again, not approved, not available, not ready, but this is in the black market. But it's one of the first molecules that generally looks like exercise in a bottle at a molecular level. So think of it as Ozempic for your mitochondria, except it doesn't make you nauseated and actually encourages you to move. So stay tuned. The future of anti-aging may be aerobic, even if your patients aren't. But this is something, again, just to keep an eye out for, and just to educate our practitioners out there, and maybe ask your patients if they're using it.
How do you get it?
Right now, you could look at a research, again, where you get these peptides that are for research only.
Okay.
Where my patients are getting it from are in these bodybuilding websites.
Okay.
So again, like the peptides that we are currently getting scrutinized for, this is something that you're going to see in that level. So you could look at websites, and it will be in the classifications of peptides as well.
Okay.
Is it marked not for human consumption like the peptides are?
Well, yes, unfortunately, but bodybuilders, I have seen them, they use it. Of course, they're already huge and big, but there's the wonder of this is you're doing cardio without doing cardio. That's what they're claiming. And it's basically increasing your energy expenditure without even doing the cardio metabolic exercise.
How long have you been taking it?
Oh, not me.
I know, I'm just kidding you.
I wish with this girly frame of mine, I don't think I need more than Sloop.
But is this synthetic? This is synthetic?
Oh, it's something created in the lab.
Yeah, it's actually part of the stack with Kylie's friend Jay Campbell.
Oh, you see it in his store?
Yeah. They push that a lot. So
yeah, so it's Sloop, and that's why it's big. It's because you're running on a treadmill without you even running on an actual treadmill.
Wow, amazing.
Yeah. So
yeah, let's make them use it first, and let's see if they grow little tails, maybe we should back off a little bit.
we can do that.
I'll be a group test subject.
You know, I had a conversation with my patient saying that really we have to salute these bodybuilders, because they are actually studies that does not even need consent. They're just going out there just to try everything for us and show us results about it, and maybe even side effects, without even actually going through a full study that you need to be paying for.
Okay. Thank you, Dr. Nario. Well, our time is upon us. We will not be speaking of this again. Thursday we start, and we are very excited. We have a really great program. We've added some more after hours dinner on Thursday night. Those of you who are coming and don't know. So Thursday night we have Chris Costa playing. He's a local one-man band, and he plays everything from the 40s to the 70s. Grateful Gardens, which is an organic restaurant, will be catering that for us. Friday night we have Tea and Keys, and we have a sit-down dinner for that. We have sponsors for every breakfast and lunch. And we still have room for you, and we really love to see you. I know it's only 2 days away, but if you can make it, great. If not, it's online. 20 AMA CME credits, category 1. We've had to shift the agenda around a little bit for to accommodate folks, but it's pretty much the same lineup. And the online is very robust. We have 2 new speakers. We have Lancet Van Gilder will be speaking about airway and the use of breathing for health. And then we also have on I think it's Friday. We've added who did we add? Oh, Colleen Huber, and we'll be talking about a pectoral muscle strategy to help treat breast cancer. So those are 2 new speakers that we hadn't had before. Like I said, 20 AMA CME credits. Next week, we will be talking about what a great time we had, and those of you who are out there in TV land will have missed it. So that's for next week. That'll be next week. We have swag bags. I don't know if you can see this. Can you see this thing? You're going to get this thing here. There.
Nice.
Can you see that? We got a swag bag. We got a what do you call that thing? It's a plug for
Charger.
it's a multi-charger. It's got our logo on it. We have gift bags. We have pens, pencils, all that good stuff. So you only get this stuff if you're in-house. So make sure you get there. And
Get a man first, huh?
Dr. Tano and Dr. Cerna, you're in tomorrow night at Bricks. So Dr. Tano, get in touch with me. We'll get you over. It's close to the hotel if you're staying there. We're meeting at 5 o'clock with the staff for the final rundown, and we'll take you over there. It's only like a 5-minute drive or a 10-minute walk, but Reno's it's dark and it's a real busy street, so we don't want you walking on the street there. Okay, so you 2 are in. Anybody else who's going to be in Reno tomorrow night before 6:30? Let me know. I can get you in. How about Adam? Are you coming?
I land at 8 o'clock.
Okay, all right. So
We'll leave some food for you, Adam.
okay.
So where are we meeting?
Well, it's at Bricks Restaurant. You know where that is, right?
Yeah.
Okay, so that's at 6:30. We're going to be at the hotel, where the conference is at 5 for a final run through with the hotel staff and our IT people to make sure everything's working. So we'll be there at 5, and at 6:30 we have it's T Lando, which is a testosterone on and decanoate that's dinner, and they have a big muckety muck who was one of the big speakers at the Androgen Society when I was there in San Francisco, coming to speak. He's a big researcher. So
Just to clarify for our Filipino or international audience that we will have recordings, and Kevin is there to verify that, but I'm sure we're going to have recordings for everybody.
He says
saying that because their time is actually starting at 11 p.m. and it ends at 8 a.m. So basically, they're going to be sleeping.
I was in a conference over the weekend that was in Bangkok. So they originally had
they
originally had me scheduled at 2:45 a.m. my time. They moved me up. They were nice. They moved me up to 11:15 p.m. So it wasn't so bad.
That's a big help.
Yeah, so that was a big help. So yeah, the Filipino people, and I've done some in London where they started at 11 p.m. LA time where I am, and we'll make sure you get everything that's coming to you and a little bit more. So okay, so we're looking forward to seeing everybody that we see on online here every week. And those of you that can't make it, please, we'll try and get the vendors to come on and talk to you, and we'll try to make it as homey as we can. We learned a few things during the shutdown years. So With that, are we good, Dr. Nario?
I think we're good to go.
Okay. All right. So originally I had Dennis Williams, who's a local psychologist here, and he was going to speak about brain injuries and psychiatric trauma, but unfortunately he had to drop out. So I'm decided to take this myself, and we are going to be speaking about something that Dr. Nario tells me he knows all about, but I had never heard about this until I got this from when I was at AMMG just a couple of weeks ago. And this is called the Coimbra Protocol. And I thought it was quite fascinating. And I was looking for an opportunity. I didn't realize it was going to be this quick. So some of this might be, especially at the end, might be a little disjointed because, as you can imagine, we've been quite busy here, and to put this together at the same time has been a bit of a challenge. So the Coimbra protocol is the use of high dose, and I mean really high dose, vitamin D for autoimmune issues. And it's actually been around since about 2001, 2002. I put this in because you will probably be able to get. Oh, by the way, last week with Stefan Hartman and his mother, those of you that were on and noticed that the video was not on YouTube. YouTube struck it. They decided that was medical misinformation, and they specifically cited where she was talking about the Gerson diet. And I mean, I listened to the part where she was talking, but she said she did use the Gerson diet for herself. She didn't use any, and she said what it was, and they struck that, and I appealed it, and they told me no, we're no good. So I'll try to get it up on our website. Stefan has it on his, I know that. But if you were looking for it, that's what happened to it. So Peck's bad boy strikes again. So we'll tell you what the Coimbra protocol is. And there's something in Europe called the Coimbra group, which sometimes causes some consternation. So I'll let you know what both of those are. We'll talk about the mechanistic hypothesis, which is that there's an acquired vitamin D resistance. And then we'll look at some of the clinical management components. We'll look at some of the safety factors, and we'll look at some of the research that's been done. So it's a tale of two Coimbras. There's a Coimbra University, and there's a Coimbra group in Europe. There's 42 established European academic societies that have that come together and collaborate with each other, and it's named after this city and university in Portugal. That's not what we're talking about, just so you know. So the Coimbra Protocol is a high-dose vitamin D. It was developed by a Dr. Cicero Coimbra. He's a professor and a neurologist at the Federal University in São Paulo, Brazil, and his focus is on autoimmune disease via immodulation. I know Dr. Nario told me that he knows about this. I had never heard of it before. I don't know if anybody else has any information on it or has used it or done it. But when we go through it, I have dozens of patients that I can think of that could benefit from this. So I'll go through it with you. We'll talk about the pros and the cons. Obviously, vitamin D is a fat-soluble vitamin. And we've always been taught that fat-soluble vitamins can have quite a bit of toxicity, which is true. So we'll talk about how we get around some of those, especially with these doses. So this was developed again, like I said, by a Dr. Cicero Coimbra, based on the idea of that there is an acquired vitamin D resistance in the immune cells that are not functioning properly. And to overcome this resistance, his protocol uses supraphysiologic doses of vitamin D3. And he emphasizes that this has to be done under strict medical supervision and with safety monitoring. We just don't go out and tell patients, take 4 or 5 or 6, 10,000 vitamin D units a day. And that's really the wrong thing to do. So the first inkling of this was in around the year 2001, and Dr. Coimbra had a Parkinson's patient. Remember, he was a urologist, and he placed him on 10,000 units of vitamin D3, and he noticed a marked improvement in the patient's tremor, but also the patient had some vitiligo, and he got the idea that maybe that the vitamin D had some issue or with towards these autoimmune type diseases. So it's been reported to be used with multiple sclerosis, vitiligo, psoriasis, rheumatoid arthritis, lupus, and Hashimoto's thyroiditis. And we'll take a little bit of look at all of these. And a lot of this is anecdotal reporting. There are some studies, but most of what I've read is anecdotal. So take it for what it's worth. The protocol can significantly reduce or even place autoimmune disease into long-term remission. And Dr. Coimbra reports 95% suppression of multiple sclerosis activity in his clinical experience. And again, these are not double-blind studies. These are not peer-reviewed studies. I mean, these are his observations. Whether you want to believe that or not, we take that with a grain of salt. So, but again, he emphasizes this, and in all the literature that I read, this is an experimental therapy. It must be administered under supervision of a qualified physician. High-dose vitamin D can cause permanent kidney damage if misused or if improperly monitored. And I have personal experience with this. I had a patient in 1990 when I was in Wilkes-Barre, PA, Northeast PA. He was 44 years old. His name was Tom. He was not in great shape. He was a very brittle diabetic. He already had two MIs. He had stents in his coronary arteries. He had a stent in his right carotid artery. It was the winter time. There was an ice storm, and I got a call at night that Tom was in the ER and he was having seizures, which were new. And he'd been there about an hour, and they weren't able to stop them, and he was on maximum doses. Everything that they had done, all the studies that they had done up to that point, and indeed afterwards, the only parameter that was off on him, other than his blood sugar, of course, was his calcium level was about 15. I think it was 15.2, if I remember correctly. And at least at that time, somebody comes in cold, having seizures, new onset seizures. It was either a head injury, but with a calcium of 15.2, this was a brain tumor until proven otherwise. Well, Tom did not have a brain tumor. He didn't have any tumors, and we scanned him from stem to stern, and we couldn't figure out anything was wrong with him except that his calcium was high, his heart rate he was in an atrial fib and an atrial flutter going back and forth, and he wasn't waking up. So usually with a patient like this, what we do where we live is we would helicopter them to either Philadelphia or New York, because we didn't want him to pass away on our watch, especially since we didn't know what was wrong with him. Now, you have to remember, we're going to get to vitamin D. We did not draw vitamin D levels on anybody. In fact, it was on nobody's radar. And I called in a neurologist, a neurosurgeon, an endocrinologist, and a couple of internal medicine specialists, a cardiologist, and everybody. We all threw up our hands. Nobody knew what to do with him. And the weather was bad, so we couldn't. The helicopter wasn't riding. So I called his wife, and I told her what the story was, and that we didn't know what was wrong with him. And she told me, let me back up. I have to give you two pieces of information, and the story will make sense. About a year before Tom showed up in the ER, Sam's Club had opened in Wilkes-Barre. And you remember, like Costco, Sam's Club at that time, you can get the 14 rolls of paper towels for about $6. And the big scandal was that you had to buy a membership. I think it was $10 at the time. And, everybody there was up in arms. So Sam's Club, number one. Number two, Northeast Pennsylvania, it was where coal was discovered to be used for heat. And there was a huge influx of Eastern European ethnic folks from Poland and Slovakia, Romania. And some of those folks bring their traditions with them. And even though it wasn't my tradition, when we had kids, and when the kids come over and their friends come over, one of the traditions there in that from that community was that mom would put a candy dish at the stairwell. And even though it was coal country, every house had a basement, not like Reno. And so you had a basement, first floor and second floor, and mom would put a candy dish at the stairwell. And I remember it was 1990, 1991. No fat diets were all the rage. So if you had an avocado, you were going, or some coconut oil, you were going to die. But you could have no fat raspberry vinaigrette, high fructose corn syrups, salad dressing, or mom could put Reese's Pieces and Kit Kats and M&Ms and any other kind of chocolates in a candy jar and candy bowl at the stairwell, and your reward for going up and down the steps is you took a scoop of candy. Okay, so you got the picture. Sam's Club, candy dishes. So his wife says to me, I don't know if this matters or not, but 6 months ago, he went to Sam's Club and he bought 6 bottles of vitamin D. Now, you remember, Sam's Club's like Costco, the bottle of vitamin D has 1,000 pills in it. And it turned out to be, what we found out later, a 5,000 IU pill. And she said, and he went back last month and he bought 3 more because he had finished them. He dumped the vitamin D in the candy dishes, and every time he went up and down the steps, he took a scoop of vitamin D. He heard it was good for. I remember her saying he heard it was good for his condition. So, and he went back a month before he came in with these seizures, and got 3 more bottles, and she said there's only 1 bottle left. So he took 5,000 unit pills in 6 months. I did a rough calculation. It was about 150,000 units a day of vitamin D. And we're going to see that some of these treatments actually have used more than that. But there's guardrails here. So anyway, nobody did vitamin D level. We didn't even think of doing vitamin D levels. In fact, our hospital didn't even have the reagents for it. We had to wait because the weather was bad to get the reagents from Johns Hopkins, which was 4 hours away on a good day. When we finally got a vitamin D level on them, all he could tell us was it was greater than 900. And we did everything we could think of, plasmapheresis, we did dialysis, nothing worked. I mean, he passed away. So that's my experience with vitamin D. Now we do vitamin D levels on everybody, and we probably do it 2 or 3 times a year on our patients. So hopefully that won't happen. Somebody comes in and they got a vitamin D level of 112, we start telling them it's a little bit too much. So the point is that if you're going to look at this type of therapy, we need to know what we're doing. We need to, be vigilant because these patients can get into trouble. And again, like Dr. Burgess says all the time, safety, safety, safety. We need to monitor the calcium, ionized and unionized, the renal function. And you're going to see in a few minutes, we actually dose via the parathyroid hormone and not 25-hydroxy vitamin D. And mandatory, they have to be on at least 2.5 liters of fluid a day. And there's no negotiating on this. You have them sign, a consent, and they have to do this. And a low calcium diet, less than 500 milligrams a day of calcium. So that cuts out dairy mostly, and calcium carbonate, antacids and things like that. Okay, So vitamin D is a master regulator of the immune system. We've all heard it's been called a prohormone. It has T regulatory cell properties, and it increases calming cells that prevent or they are anti-inflammatory. They decrease the Th17 cell line that drives inflammation. Beyond vitamin D, rather bone health, vitamin D functions again as a prohormone. It aids in the function of growth hormone and cortisol, stress hormone. Low vitamin D levels are consistently associated with higher risk and greater sensitivity of autoimmune diseases, including multiple sclerosis, lupus, type 1 diabetes. And it has epigenetic influences over 200 genes that are involved in immune regulation. So the Coimbra protocol was based on a hypothesis that the autoimmune affected cells are resistant to vitamin D, similar to insulin resistance or thyroid resistance, and that's the theory behind it. They have a reduced biological response to vitamin D, either due to genetic factors, particularly vitamin D receptor genes that activate enzymes like the CYP27B1 or transport proteins. And they make these gene SNPs make the vitamin D less effective. Also, environmental factors, including infections like our old friend, the Epstein-Barr virus, Lyme disease, hepatitis, herpes, and Yersinia, which comes from a common, stomach flu, are some of the culprits here. Also, for a hat tip to Dr. Campbell, mold and mycotoxins. Consequently, normal levels of vitamin D are not sufficient to regulate the immune system, and they allow the autoimmune process to persist. This is kind of an overview of the protocol. It's at high dose vitamin D, and look at those doses: 40,000 to 300,000 units a day. I mean, that's a whopping dose. If we're gonna entertain that, we're gonna need to be on our toes here. A minimum of 2.5 liters of fluid is required daily to protect the kidneys and to help remove any excess calcium. These folks need to be monitored with blood tests and urine tests. They have to monitor their calcium, kidney function, and parathyroid hormone levels. Again, strict no calcium diet or very little calcium diet. So dairy products, calcium fortified foods, seeds and nuts are no-go. And we'll talk about some cofactors that will aid in mobilizing the calcium and increasing blood flow. And you'll see they're there. We'll give you some doses in a little bit. Okay, so conventional medicine defines 25-hydroxy vitamin D as normal now is 30 to 100. I know it says 50 there. We've gone through many times. If you want me to, I'll tell you how we get to our optimal of 50 to 80 nanograms per milliliter. But as recently as a year ago, there was a video on one of the ViewMedi or something from a professor at the University of California, San Francisco, arguing that any values of 25-hydroxy vitamin D over 20 are not necessary. So, that's the conventional wisdom. The Coimbra protocol declares that this is insufficient. And again, we're dealing with vitamin D receptors that have SNPs on them that do not respond properly to usual vitamin D doses. Again, the immune regulatory effects of vitamin D are not fully achieved when blood levels are so-called normal. And again, as I mentioned before, it's analogous to insulin resistance and or thyroid resistance. We use supraphysiologic doses of vitamin D3 to overcome receptor resistance and to restore proper immune balance. Down here, this little chart here shows the the progress of vitamin D as it goes from sunlight through the skin, the liver to 25-hydroxy vitamin D3, and it goes through the kidneys, and it activates hormone binding receptors to affect its expression. These changes in the genetic variants. The changes affect binding strength and signaling, and they weaken the cell's response to vitamin D. The two enzymes are CYP2R1 25-hydroxylase and CYB27B1 1-alpha hydroxylase are the two enzymes that are affected in this vitamin D resistance syndrome. Genetic variants in this enzyme reduce the conversion of vitamin D3 to 25-hydroxy vitamin D in the liver, which is the first critical step in vitamin D activation. And the 1-alpha hydroxylase enzyme polymorphisms affecting this enzyme impair the final conversion to the 1,25-hydroxy 2D vitamin D3 in the kidneys, directly limiting vitamin D's immunology capacity. Can't say that word. Environmental factors can impair vitamin D resistance, as well as the genetic factors. So we talked about the pathogens, Epstein-Barr, Borrelia with Lyme disease, cytomegalovirus, and again, Yersinia, mold, mycotoxins, herpes, hepatitis are the main culprits. High cortisol levels weaken vitamin D receptor activity, and this can happen through direct receptor interference, or it can disrupt the gene transcription patterns. Aging, skin production, vitamin D production diminishes with age. Intestinal absorption is also affected as patients mature. Kidney activation of vitamin D is impaired via the senescent cells in the body, and the aging increases your vitamin D resistance. I don't know if Dr. Halas is on. Here's his favorite, Th1 to Th2 and Th17. And before, with vitamin D resistance, we get increased inflammatory cytokines, particularly TNF-alpha, interleukin-6, interleukin-17. The high-dose vitamin D3 will overwhelm the inactive cells and increase Treg cells, decrease Th1, Th17 overactivity, decrease pro-inflammatory cytokines, and decrease the autoimmune incidences on the affected tissues. Again, vitamin D is a pro-hormone, not just a vitamin. It actually aids growth hormone and cortisol in their production and repair. Remember, cortisol and growth hormone are both generated with sleep, usually between the hours of 10 p.m. and 4 a.m. And one of the issues with traveling long distances and disrupting your daily rhythm is the disruption of cortisol, stress hormone, and growth hormone. And again, the vitamin D receptor complex can modulate up to 1,200 genes have been identified. So they can be both innate and adaptive genes in adaptive immunity, and vitamin D reshapes the immune cell behavior and inflammatory responses. So vitamin D will increase your regulatory T cells. It promotes immune tolerance, and it promotes it will boost the Treg differentiation and function, which is crucial for immune tolerance. It helps suppress the autoimmune reactions that can occur. And vitamin D lowers pro-inflammatory Th7 T cells, which are the major drivers of many autoimmune functions, particularly in multiple sclerosis, psoriasis, rheumatoid arthritis, and lupus, and Hashimoto's thyroiditis. Vitamin D shapes the B cells and T helper cells, affecting their differentiation and proliferation, and shifts the immune system towards a more tolerant anti-inflammatory state that counters the autoimmune progress. Sorry about the slide here. So the Th1, Th17 pro-inflammatory cells promote inflammation, drive autoimmunity, and the Treg cells, which suppress the effector cells and maintain tolerance. The therapeutic goal of the Coimbra protocol is to reset the immune balance to the right-hand side of this chart. And it shifts the Th17 Treg ratio towards immune tolerance. We use individual dose strategies, and we can use doses anywhere from 40,000 to 300,000 units a day. There's some disease-specific starting doses. On average, a starting dose is about 1,000 units per kilogram, which is a lot of vitamin D. So, if you have a patient that weighs 220 pounds, usually a male, that's 100 kilograms. So 1,000 times 100, that's a lot of vitamin D. It's that 100,000 units a day. And that's usually the starting dose in most of the protocols for autoimmune disease. A little bit less with psoriasis, rheumatoid arthritis, lupus, and irritable bowel syndrome, 300 to 500 units per kilogram. This is per day. And for Hashimoto's, 150 to 300 units per kilogram per day. Doses are individualized, though. They're not fixed. And we are going to vigorously test their calcium levels. We will look at our 25-hydroxy vitamin D because it's conventional, but you dose according to the parathyroid response and disease activity.
Usually got to move it. It's not set on there properly.
What's that? We can mute whoever that is. And ongoing optimization. I would, if we're starting this protocol, probably test these folks before we begin the protocol. I would test them probably once a month for at least 3 to 4 months, and then at least every 3 months after that. We modify the doses up or down to meet the therapeutic goals, which are to lessen the autoimmune response. Again, the goal is to get sufficient substrate, sufficient vitamin, 25-hydroxy vitamin D, vitamin D3, to saturate the resistant receptors and normalize downstream immune signaling despite impaired receptor function. We're not looking for normal 25-hydroxy vitamin D levels. Remember, normal's 30 to 100, optimal's 50 to 80. If you use these protocols, you're going to get levels in the 150, 200, 300. But if we get suppression of the parathyroid hormone and do the other things that are necessary, we should be able to get the patient safely through this and reduce the autoimmune response. So parathyroid hormone and vitamin D are linked in a tight feedback loop that regulates calcium balance. Active 1,25-hydroxy vitamin D3 will suppress parathyroid production as the vitamin D activity increases. And this makes the parathyroid hormone a biomarker of functional vitamin D receptor. The 25-hydroxy vitamin D will always rise with supplementation of vitamin D, even if the receptors are resistant. So we're getting a false reading with the 25-hydroxy vitamin D. Parathyroid suppression, by contrast, signals that the vitamin D is actually binding to the vitamin D receptors, and we're getting the biological effects. Not unlike getting serum magnesium levels and then red blood cell magnesium levels. The numbers are very different, and what we're looking for is the magnesium getting to the cells and not just in the serum. And I postulate we gave some talks at AMMG on serum laboratory tests as part of our laboratory series. And the same thing, we look for that with testosterone. So serum testosterone levels are not the same as tissue testosterone levels. For the tissue testosterone levels, we're looking at probably saliva, RBC testosterone, or urinary metabolites. So the same thing here. The 25-hydroxy vitamin D levels can be high normal, or very high, but what we're looking for is parathyroid suppression. You want to suppress the parathyroid into the lowest third of the reference range, and this indicates you're getting biological vitamin D effect, and you're optimizing your Th17 Treg balance. The therapeutic level for your parathyroid is about 10 to 13 picograms per milliliter. Normal is, according to LabCorp, is 15 to 65 picograms per milliliter. So we're less than a midpoint. Midpoint is 40. So we want it to be less than the midpoint, and it could even be a little bit below what is that wide range. You don't want to push the parathyroid to zero, though. That will cause calcium to be mobilized excessively, and we're going to end up with long-term bone and renal risk. So again, some is good, too much is not good. The exact sweet spot of our lab values varies a little bit by lab. You make sure that, again, there's a difference between the two major labs where I am, are LabCorp and Quest, and you have to look at their reference ranges because they're sometimes a little bit different. And so, for instance, for Hashimoto's thyroiditis, the thyroid peroxidase antibody for LabCorp is normal is less than 0 to 34. Our optimal is 20 or lower, but for Quest, it's 0 to 9. So if we draw a TPO at Quest and we get a 15, and then we draw it again 3 months later at LabCorp and get a 15, the 15 at LabCorp is normal. The 15 at Quest is high. So again, pay attention to your calibrations there. You want to bring down the parathyroid hormone by at least 30 to 40% from the baseline. Make sure you keep it detectable, though. You don't want it to go very much lower than the lower end of normal boundary. And we need, again, to monitor ionized calcium, unionized calcium, also creatinine, urinary calcium to ensure patient safety. This was a study done by Lemke. I have the reference a little bit later on, but these are the parathyroid levels over a year using for 41 MS patients. And I think the dose here was 35,000 units of vitamin D a day. And this was the beginning parathyroid range here, anywhere from about 25 to about 55. And as you can see, it's been suppressed once we started using the high-dose vitamin D. And it stayed pretty steady here in the 15 to 20 range. Okay. And reducing the parathyroid concentrations is just as an indicator of overcoming vitamin D resistance. This is from a different study, and the numbers look pretty much the same, a little bit color coordinated there. This is the study here by Lemke. You can get the reference if you want to look that up yourself right there. So why not use 25-hydroxy vitamin D levels to measure the vitamin D? High-dose vitamin D will cause a sharp rise in the 25-hydroxy vitamin D levels. It will rise even if it's not getting to the tissues, though, and it's not exerting the immune effects that we're after. It's not a reliable marker of cellular vitamin D activity with vitamin D receptor resistance. And 25-hydroxy vitamin D levels can coexist with poor vitamin D receptor signaling and suboptimal immune response. The vitamin D, 25-hydroxy vitamin D levels can reach 200 to 400 or even higher. But again, we're going to look at the parathyroid hormones, and we're not going to, as long as it's suppressed, but not too much, we're not going to panic at all. That's our guide. Okay. Other items that need to be addressed here: diet, hydration, and monitoring. So again, high dose vitamin D will greatly increase intestinal calcium absorption. And remember, my patient Tom, his calcium was 15.5. I think normal is about 9 to about 11. It elevates calcium to dangerous levels, and indeed, that was the source of Tom's seizures. Vitamin D is needed for the immune modulation, but we have to be cognizant of calcium toxicity. We need to strictly limit calcium. And we tell our patients when we do this, it's a Judge Judy deal. It's a yes or a no. Either you're doing it or you're not doing it. And if we get any hint that they're going to be using dairy and they're not going to comply with it, you gotta stop this right away, because we can do damage if we don't. So milk products, dairy products, nuts and seeds, calcium fortified foods and beverages. The protocol does allow for a little bit of calcium intake, usually less than in half, probably a third of standard recommendations of 500 milligrams a day. Non-adherence risks hypercalcemia. It can lead to kidney damage, nephrosclerosis, kidney stones, and cardiac rhythm disturbances. That's what happened to Tom, and we couldn't get him out of it. Again, it took us 5 days to figure out what the problem was in the first place, because nobody thought of vitamin D back then. Calcium restriction and fluid adherence is mandatory. This is non-negotiable. And all of you are clinicians know what I'm talking about. Cardiovascular issues. Again, Tom had serious atrial fibrillation and atrial flutter from the high calcium levels. Neurological, he had new onset seizures. He never did wake up, and he passed away about 2 weeks after coming in with his with his high calcium from his high vitamin D. Now, admittedly, he did it himself, and he didn't take any of these precautions. And we weren't cognizant of the fact that he had used vitamin D, and we didn't really know what to make of it, because I remember I had one line in medical school. I remember vitamin D is a poison. It's a fat soluble vitamin. It will, if you take it, it'll stick with you. The only thing it's good for is youngsters with rickets, which you don't see in North America. So just ignore it. I remember that was it. That's what I learned about vitamin D in medical school. Overcoming multiple sclerosis, which is a multiple sclerosis society, does not endorse the Coimbra vitamin D doses. And again, I can't emphasize enough, we can get into big trouble with this. So do's and don'ts for a low calcium diet: keep the calcium low, stay away from calcium fortified foods and drinks, plant milks, juices, cereals, dairy, cheese, yogurt. Healthy plant-based entities does not mean it's low in calcium, and there are no cheat days. Okay, and you have to be strict about that. Low calcium foods, grains, which most of us stay away from, vegetables, fruits, fresh meat, eggs, and again, healthy fat oils. Read the labels, check the calcium percent of your daily value, and the patients should probably keep a diet diary, would be a good idea, and have them track their calcium intake. What can they eat? Grilled meats, fish, rice, pasta, potatoes, non-creamy vegetables. You can use healthy fats and oils, olive oil, avocado oil, coconut oil. A little bit of butter is probably okay. Fruits and vegetables. Stay away from high calcium greens, however. And find out what the ingredients are. Sauces and cheeses, please leave them off. Almonds, cashews, pistachios, sesame, tahini, chia, and flax have calcium in them. Canned fish with bones is a taboo. So canned sardines, salmons, and don't overlook hidden dairy in soups and dressings and baked goods and protein bars and non-dairy creamers. Okay. So hydration, I mentioned this before, 2.5 liters of fluid daily, low calcium water and low calcium beverages. High fluid intake is critical to prevent kidney damage, and fluid intake is mandatory. You need adequate hydration to ensure a high urinary output, which will flush the calcium from the kidneys. And it will lower urinary calcium concentrations. It reduces the risk of calcium crystal formation and kidney stones. You want to prevent nephrocalcinosis. High fluid intake prevents calcium deposits in the kidneys. If this happens, it can be irreversible and can lead to progressive permanent kidney damage. So fluids are critical. There's some cofactors that need to be used alongside of the high dose vitamin D and the fluids. Magnesium is critical, and we like magnesium glycinate here, 200 milligrams twice a day, and magnesium taurate if the patient is having sleeping issues. Stay away from magnesium citrate. That can cause GI. That's what we use in the colonoscopy suite. So stay away from that one. The magnesium is essential cofactor for the hydroxylase enzymes that convert the vitamin D to its active form. And low magnesium is underdiagnosed. If you're going to get magnesium levels, you need the RBC magnesium, not the serum. You have to specify on the lab slip RBC magnesium. Omega-3 fatty acids, 2 to 4 grams a day for a minimum of 6 months. These are anti-inflammatory. It enhances vitamin D function. It maintains cellular membrane health. It optimizes immune cell health. It's a bit of an antiplatelet agent, and it has antidepressant properties also. So overall, always a good take. We measure C-reactive protein. Now, that's not for this protocol, but we measure C-reactive protein levels on all our patients. When the C-reactive protein is greater than 1, we usually recommend the omega-3 fatty acids. Riboflavin, vitamin B2, 50 milligrams, 50 to 200 milligrams per day. This supports energy metabolism, maintains optimal immune function, and reduces kidney stone risk. Here's a table of all of the cofactors, but remember the top two, magnesium and riboflavin, they should be mandatory along with the fluid and the vitamin D. Methylated B vitamins support homocysteine control. They address deficiencies in autoimmune patients. Try to avoid very high B6 long term, and tailor the folate, B12, MTHFR variants with anemia. Remember, you can get with a B12 folic acid deficiencies, peripheral neuropathy. Vitamin K2, 100 to 400 micrograms per day. It directs calcium into the bone. It helps protect blood vessels, soft tissue from ectopic calcification from high-dose vitamin D. Use this with caution on vitamin K antagonists, i.e. the blood thinners, warfarin, and the others of such. Is not a substitute for calcium restriction, however. So it does drive calcium into the bone and lowers the serum calcium levels. But again, it's not a substitute for calcium restriction. The omega-3 fatty acids, we already covered that one. Selenium, which is one of your, I call them ingredients that make up the thyroid hormone the precursor, along with iodine, is an antioxidant. It's an immune modulator. 200 micrograms of selenium daily for about 4 months can decrease thyroid antibodies by up to 40%. Stay below. I know Stefan likes 200 micrograms twice a day, but you sometimes can run the risk of some the toxicity at those levels. So just be a little bit careful there. Zinc, 15 to 30 milligrams, will improve the immune function, wound healing, taste and smell. Long-term high-dose zinc can deplete copper, and most of the supplements that we use have a zinc copper component to them. Iron corrects anemia, improves fatigue. 25 to 65 milligrams of elemental iron. We use iron bisglycinate. We get a 28 milligram a tablet, usually just once a day. And we usually confirm the deficiency either with a serum iron and total iron binding capacity or a ferritin level. You'll see low ferritin levels, particularly in Hashimoto's thyroiditis. And vitamin A, you want to, again, is another fat-soluble vitamin. Remember, the fat-soluble vitamins are A, D, E, and K. You don't want too much. You don't want too little. We actually use vitamin A quite frequently for our viral URIs. I'll give you a little formula that we use. We get 25,000 units of vitamin A, 5,000 units of vitamin D. We'll use 6 of the vitamin A, 150,000 units on day 1 of our protocol for coughs, colds, URIs, viral infections, with 15,000 or 3 vitamin Ds. On day 2, we'll use 4 vitamin A's, 100,000 units, and wait, that's wrong. Day 1, we'll use 6 and 3, so 150,000 and 15,000 of D. Day 2, we'll use 2 or 50,000 of A and 1, 5,000 of D. And day 3, we'll use 4 or 100,000 and 2 vitamin D, 10,000. So it's 6 and 3, 2 and 1, 4 and 2. And we've used that for a long time with really good success. So there's a little extra tip there for you. So we talked about fluid intake. Calcium, we want to restrict that to 500 milligrams per day. And we're going to avoid dairy. We're going to be careful of nuts, seeds, fortified foods, no calcium supplements or calcium-based antacids. And citrate support, namely water, lemon water, or potassium citrate, will bind with the urinary calcium and reduce stone formation. Avoid it in renal failure or hyperkalemia, the potassium citrate, and go with the lemon water. Laboratory monitoring, again, remember, this can be dangerous, so we want to be careful monitoring. So for calcium homeostasis, we're going to do total calcium, ionized calcium, unionized calcium, serum phosphate, and parathyroid hormone. For renal function, we'll do the serum creatinine. We'll get a BUN also. We'll also get that cysteine C, which is a more sensitive marker for renal function. And sometimes we'll do a 24-hour urinary calcium excretion. Periodic imaging, we'll do a DEXA scan, and we'll get an annual kidney ultrasound to detect nephrocalcinosis or stones if they're on the protocol for that long. So that's our evaluation and our monitoring. 24-hour urinary calcium excretion is the most sensitive marker for deciding when to lower or pause vitamin D. A lot of patients don't want to be carrying a bucket around and peeing in it for 24 hours. A safe level for 24-hour urinary calcium is less than 250 milligrams per liter. At that point, we can continue on as before. The danger is if it's more than 250 milligrams per liter, we stop the vitamin D for 3 days and then we decrease the dose by half when we do restart it. Maintain the fluids and then restart at a lower daily dose. Exercise is actually part of the Coimbra protocol prescription. And again, this is not a suggestion. Exercise is an integral part of this. High dose vitamin D and calcium restrictions increase bone turnover and reduce bone density over time. Weight-bearing aerobic exercise can counteract that, and especially by providing mechanical stress to maintain bone strength. Exercise counteracts the skeletal effects of the low calcium intake on this protocol, and exercise supports cardiovascular health, metabolic health. I don't need to go into it with all of you, the joys and the profits of a good exercise program. So what do we know from the research? So there are pilot studies, there are case studies. There's no big pharma, 20 a unit, 600,000 cases to be studied. There are no, as far as I know, long-term randomized controlled trials with the statistical power necessary for the publications that are required. And there's a lot of disagreement in a lot of worlds, and I'm sure when I'm finished, I'm going to hear some disagreement when we talk in the chat. Okay, so this was a study in 2013 by Finnemore. The reference is down there in at the bottom, and this was they used a fixed dose of 35,000 units vitamin D3 for 6 months on vitiligo and psoriasis patients. They reported no toxicities in any of the patients as they were monitored carefully. And they had, again, high hydration, low calcium diet. And this is the percentage of patients that had improvement, significant improvement. And again, some of this is subjective on the protocol here. So greater than 80%, you can see in the vitiligo and psoriasis patients. This is one of the patients here. This was before. This was after. 6 months later, you can see there's quite a big change here. This patient was extremely satisfied with how things went. These are the 25 hydroxy vitamin D levels at the baseline here. You can see it's about 35. And it would fluctuate between 80 and 120 on the protocol. These are parathyroid hormone, and as you can see here, remember 15 to 25 to 65 is considered normal, and we see the patients sort of here anywhere from about 45 to about 65 pre-treatment. 6 months later, you can see they're down in the 15 to 20s. This is where we want to be here in the lower third of the reference range. This is a patient with vitiligo, and although you might say, well, this wasn't all that dramatic, we were able to get some repigmentation here in the hands and feet. This was after 6 months. This is a long-term treatment, and as you can see, her face is actually much better than her hands here. So this was actually quite encouraging to see this. Neurological, there are numerous case reports, again, with the high-dose vitamin D with a moderate success. This was one by Aman and high-dose vitamin D, 3.5 years, 319 autoimmune patients. 65% of them were female. Average age was 43. Average dose was 35,291 IUs. That was for this was an MS study. These were, I think this was vitiligo over on this side here. Again, safety measurements, and because paying strict supervision paid off. These are the diagnoses that have been tried and used and have been written about with on this protocol. And vitiligo is the most common. Alopecia areata, autoimmune thyroiditis, multiple sclerosis, rheumatoid arthritis, Crohn's disease. You can see all of them here in psoriasis. So all the common autoimmune issues. Primary outcome was in this study was to reassure safety and measure all the measurements and mean values for total serum calcium, creatinine, estimated GFR, and 24-hour urinary calcium excretion remained within normal reference range. And it was pretty significant since the patients were on an average of 35,000 units per day. and the MS patients were on an average of 53,000 units per day. Correlation analysis, there was a weak relationship between oral vitamin D3 and serum or urinary calciums, suggesting that strict dietary calcium restriction and hydration will mitigate the calcium elevating effects of high dose vitamin D. Parathyroid levels were significantly decreased across the board for the MS and non-MS patients, confirming their biological effect of high-dose vitamin D on calcium homeostasis. Parathyroid hormone plateaued at different levels in different groups, and it was dose dependent. Multiple sclerosis patients reached a lower parathyroid plateau than non-multiple sclerosis patients, consistent with higher doses needed for those neurological interventions. The differential pattern supported individual dosing and shows that parathyroid suppression tracks vitamin D dosing. And again, here's the reference for that. Molecular support. In this study, the subgroup of 130 patients, genetic testing revealed that about 75% of the patients carried 4 mutations of the vitamin D receptor SNPs across different gene lines, which was a pretty high prevalence for just one vitamin D genetic markers. So you can imagine if we expand this to all of the vitamins, we could have a field day here. So we have gene variants, we have impaired metabolism from them, we get relative vitamin D resistance with the need for vitamin D high dose vitamin D to overcome. All right, so what can go wrong? Nephrocalcinosis, calcium deposits in the kidneys, and it can cause permanent kidney damage, structural damage, and functional damage with progressive loss of renal function that can become irreversible. Nephrolithiasis, kidney stones, calcium containing kidney stones, which are acutely painful. There's urinary obstruction, recurrent infections, and these folks end up going to the OR quite frequently. And then there's cardiac disturbances. We talked about that. Cardiac arrhythmias, shortened QT intervals, atrial fibrillation, atrial flutter. And in some severe cases, and eventually this is what did Tom in, was cardiac arrest. There was a case of hypercalcemia and renal insufficiency in an MS patient taking 100,000 units a day that highlighted that toxicity is a possibility and to not take this type of protocol lightly. Upon further investigation, the patient was identified as a carrier of the MEN1 gene, which causes elevation in parathyroid hormones prior to the starting of the protocol, which was a pre-existing condition. So the lesson here is the necessity of a thorough baseline screening. And I guess you're going to have to do some genetic testing also before you initiate high-dose vitamin D. Self-treatment. So, it's easy. You can go get vitamin D, anywhere. You can go get it at the dollar store. You can go get it at Walmart. And self-care is a problem because, these patients and even, medical personnel kind of tend to forget sometimes. When they self-treat or they fail to follow, the protocol to a T, they can run into bad problems. I'm a medical doctor. I know better. I know what I'm doing. And again, vitamin D is over the counter. And so self-administration patients can run into severe problems like Tom. And then some patients do some of the protocol, but not all of the protocol. Again, with the cofactors, particularly with magnesium, they'll leave that out. With zinc, they'll leave that out. They, again, run into different types of toxicities. What don't we know? There's no long-term randomized controlled trials with extended follow-up periods. The long-term effects on bone density with chronic calcium restriction, we don't know that. Cardiovascular outcomes with sustained high vitamin D, we don't know that. Cancer risk modifications could be better, could be worse. Neurological effects of chronic high-dose exposure. I think we had an inkling of that with Tom and his seizures that became status epilepticus, and we were unable to break them. The durability of the autoimmune remission after many years of treatment, can it become a permanent thing, or is the high-dose vitamin D permanent? We don't know that. and safety of treatment beyond 3 to 5 years. So, is it plausible? Yeah, it's doable. The immunologic research on vitamin D effects on Th17 Treg cell balance and vitamin D receptor polymorphisms, has been done. It's not proved by, our gold standard of peer-reviewed studies with long-term follow-up. And there's preliminary evidence exists with pilot studies showing promising results. And again, since I started, it is potentially dangerous. So here's a sort of an overview of a treatment for autoimmune disease developed by Dr. Cicero Coimbra to suppress autoimmune activity. High dose vitamin D to overcome vitamin D resistance. We want to lower the parathyroid levels with the lowest third of the reference range. It has to be done under strict medical supervision. We need high fluid intake, at least 2.5 liters per day, strict low calcium diet, and constant lab value monitoring. The individual doses, usually we start at 1,000 units per kilogram per day. And daily doses they can actually be adjusted due to lab markers. And so it's never a fixed amount. Again, 2.5 liters of fluid per day to protect the kidneys, regular monitoring, the cofactors, including magnesium, vitamin B2, riboflavin, omega-3 fatty acids, vitamin K are essential, and need to stay away from any type of calcium type foods that risk hypercalcemia. When a patient asks about the Coimbra protocol, if they've started on it, we don't stop it. We don't stop any current therapies. We don't discontinue any proven disease-modifying treatments, multiple sclerosis agents, immunosuppressants, without a careful plan. This is not for everybody. They need to be confirmed as having some sort of autoimmune issue. With inadequate response or intolerance and ability to work with a physician closely, or the physician's extenders to monitor fluids, to monitor diet, and to make sure that they're using all of the cofactors. This is an adjunct option. It's not a replacement for anything that is evidence-based and is never a do-it-yourself. Again, we're in Reno starting Thursday morning at 8 a.m. We want you there if you can make it. If you can't make it, online, congressofmedicalexcellence.com, and 20 AMA CME credits. And here are all our speakers here. We got Pete Dimitri, we got Marlene Siegel, we got Dana Ullman, we got Bill Richards. We have Felice Gersh, who's very famous in the hormone world. Thomas Levy is coming up from Colombia to be with us. He's going to be doing 3 hours for us. Dr. Sahar Swadan, who's a hormone expert from Ann Arbor, Michigan, and she's I think she's number one now. She's the number one instructor at A4M in the hormone world. And we're going to have integrative oncology with Sean Devlin, heavy metal detox with Pete Dimitri, Greg Jones, who's a nurse but runs a IV ketamine clinic, will be telling us about that. Dr. Frank Schallenberger of Ozone fame will be here. So it's a great lineup. If you're in the Reno area tomorrow night, let me know. We can get you into a lecture from Dr. Goldstein, who's very famous in the testosterone research world. If you know Reno, it's at Brick's Restaurant at 6:30, but we need a reservation. Get in touch with me. The two, Dr. Tano and Doctors Jeanette Serena, you're in. Okay. So, Dr. Tano, we're going to be at the hotel at 5. If you're there, we'll take you over there. It's not far. It's not even a 5-minute drive from the hotel, but we'll take you there. It's dark, and it's a little bit chilly in Reno at night this time of the year. Anybody else wants to join us? Please let me know. I'll do my best to get you in. My contact there says it's not a problem. The only thing he does, you have to be a prescribing practitioner. So sorry, Dr. Siegel. I tried. I just told them you were Dr. Siegel. I didn't tell them you were a vet. They found that out themselves.
Can
So,
I say that she's my MA?
huh?
Can we tell them that she's our MA?
I tried. I really tried. So, um, and again, Congress of Medical Excellence 5.0 starts Thursday. It's also online, very inexpensive. So please be there with us. And that's it. I hope
I'll
you
read
like.
the questions for you.
I hope you like that. Like I said, I've learned about it for the first time. Dr. Neri, you have any experience with this? Have you used this?
Nah, I've read the protocols before. It's just as you can see, you better have good insurance for this.
Yeah, 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 yeah.
So
I have a number of patients that I'm thinking of, might be a candidate for this. So the first thing I'm doing is making a thoroughly informed consent before anything.
it better be.
Um,
I was reading through it. I think you would see the countries who are doing this.
yeah,
US is very, in terms of the number of practitioners who's doing this, they're even
I think
doing
there's five
undercover,
five in the U.S. that are doing it, from what I read.
and
So
they're not even advertising for it. So
no,
it's really out of the country, so international. That's why I think I saw India being one of the bigger
right.
countries
Mhm.
who's doing this. And I think some of the practitioners in the Philippines, if you want
Yeah.
to chime
So
in,
I mean, if we never use it, I mean, it's food for thought. I found it quite fascinating. And I kept, as I was sort of studying this and putting this talk together, I kept thinking about my patients my MS patients and my Hashi, I probably have 300-400 Hashimoto patients, actively going, and we can get their antibodies down to single digits, but unless they have, in my experience, unless they've had H. pylori, and sorry, ladies, it's only men. We've treated the H. pylori and the Hashimoto's went away. It was cured. I mean, the antibodies are gone. The thyroid disease went away, but it's only been H. pylori, the etiology of H. pylori, and only men. I don't know why. So,
uh,
but that's my experience. So there's a lot in the chat.
here, I'm going to read it for you. So from Harlan, is this different than people with VDR SNPs that you need high doses to push the gene to raise level of 25-OH vitamin D3?
So what was the question?
That was the.
I'm
Is
old.
this
I don't
there?
hear so well anymore. What's the
Is this
question?
different than people with VDR SNPs that you need high doses to push the gene to raise the level of 25-OH vitamin D3? So I think
Yeah,
it is.
yeah,
It is. Yes.
yeah.
That is.
The answer is yes there. So
Mhm.
okay,
But you've noticed that there are so many different SNPs in that process from
yeah. I
the
think there were
liver to the
1,200.
kidney.
Yeah,
Right. So I think you're trying to hit all of those SNPs,
yeah.
right?
Probably try to
Uh,
hit the big ones.
well, this is a question from Jeanette. So this is a good one. Is there a way to test for this acquired vitamin D resistance besides the genetic testing? So you would know that in genetic tests, you already have indications or I guess parameters for VDR SNPs. Can that be something that you can use in order for somebody to be eligible for this protocol?
Yeah, I guess.
So,
Unknown.
yeah, well, that's the thing. It's such like from the main pathophysiology of this problem, it's that resistance of that receptor. But if you have a test that you could actually that can tell you that they are resistant, I mean, can you base that on that? I don't know. That's
Yeah,
just
that
a
that one
question.
that one I'm not clear on. Um, so that's again, for me, this was, I found it fascinating, and it was all theoretical. I've not done any of this yet, but I can see myself doing it actually. So I have a number of,
Yourself.
not to myself. Fortunately, my thyroid disease is just the acquired from Reno thyroid issues. We're down. I've been here long enough, and we're downwind from where the nuclear testing was done in the 50s and 60s. And I heard rumor that they're going to start doing it again.
Yeah, I don't know about the perks. I don't know if there's the perks that you get from being a resident in Reno, but
Yeah, yeah.
Um, from Harlan, can homeopathy play a role to restore the receptor site? Which ones will help, if any?
I don't know.
So on my end, again, homeopathy is, as you would know, they tackle classic illnesses and diseases, miasms, and again, this I cannot answer. I do homeopathy in my practice, but again, this is more of constitutional when you approach homeopathy rather than actual receptor site pathologies. Uh, I'll probably research more on that.
Yeah. Hmm.
From Janet, how could we know if we hit the right dose of vitamin D?
Okay, so we're going to look at the parathyroid hormone
Yep.
levels, and we want it in the lower third of the reference range. So at 15 to 65 is the reference range at LabCorp. So you want it probably anywhere from about 15, no lower than 10 to about 30. And so if we start out at a fixed dose, say at 35,000 units, I would check the parathyroid levels every 4 weeks, and we'll see how it drops. And when we get when we get it to that one of those levels, that then you have the right dose.
Right.
Remember, we don't want to overdose them either. We don't want the parathyroid levels to go to zero because then we're going to end up with bone issues.
And again, this reminded me of my, I guess my tip of the week last week about vitamin D being a CYP inducer.
Right.
So a majority of these autoimmune diseases probably has also comorbidities such as hyperlipidemia who are on other medications. So again, that's something to look into when you're using these high of a dose of vitamin Ds in these chronically ill patients. Another one is, you answered this, any association of vitamin D resistance and severe trauma? I think you did mention that, right? The
Yeah,
cortisol
yeah.
levels.
Yeah, so that's an affirmative. Yeah.
For patients with vitiligo, what's the ideal vitamin D3 dosage from Elizabeth? I think that's a 35,000, I think,
Yeah,
for
yeah,
6 months.
well, that one study, they started at 35,000 on everybody at 6 months.
6 months, yeah.
Alternatively, 1,000 units per kilogram per day. So that's a much higher dose. So I would probably go 35, 40,000. That's in all the literature that you read about this type of protocol. That's sort of the bottom, the bottom of the dosing range. And I tend to be a little bit more conservative when we do, crazy things like this. So I would do 35 to 40,000, check their parathyroid levels every 4 weeks, and increase accordingly. When you get it down into the 15 to 30 range, then you found the right dose.
Okay. This is Heather. I mean, Heather is asking, this is for the conference. Do you need to be a prescribing practitioner to be online? Nope. So there is an option there that if you're international, if you're a lay person, you also have a good price to get into the conference, and even online. You don't have to be here. And
If they come, we're feeding them, we're gorging them with food here. So
I think we have
we
more
have
food
we
and
have we have
entertainment than
we have
lectures.
yeah, we have non CME talks for every breakfast, Thursday, Friday, and Saturday, every lunch. And we have two parties after hours on Thursday and Friday.
Yeah, so we're gonna make them gain weight. That's what we're
You're
saying.
gonna gain weight while you're here. So
All right, and how long do the effects of treatment last after achieving good results in general?
yeah, that's one of the unknowns.
Yeah, okay. Yeah,
Okay. Yeah.
Kylie says
The
good
answer is
question.
that's one of the unknowns. According to Dr. Coimbra, 1.5 to 2 years post achieving therapeutic levels, these patients still have good progress. The problem with it is that we don't have these, the usual studies that you do for the optimization. So, Dr. Burgess, here's another project for you.
Another research idea.
Oh boy, oh boy. Okay, hey, we can do the research, and we have to. And
Take it to Roatan. We probably need a little less vitamin D, right?
man,
Because
well,
the sun shines there.
Trump just freed the president of Honduras, but at the same time declared a war on Venezuela. So we're in a touchy situation down there right now.
Okay.
But hey,
Tell them
great.
we're there for the sunshine. We're not we don't care about their politics. Leave us out of this.
All right. Hey, just because you mentioned the subject of vitiligo, I'd like to say, because we're dealing with the other stuff too. In Sri Lanka, the United Nations program there, they were getting near total success with vitiligo within 6 months. So the bad, young cases in that area where you really see the spotted leopards going around and they're socially put down and all that. We had one lady who was kicked out of her house by her husband because she was so ugly because she had vitiligo. And with acupuncture plus homeopathy, no vitamin D, I'm just saying, just acupuncture, just homeopathy, she, like most people, were totally reversed within 6 months.
Okay.
Yeah, good stuff.
All right. What if we use lower doses? Well, the issue there is that you need to overcome this vitamin D receptor resistance, and that's why you need the higher doses. We use 5,000 to 10,000 units, routinely on just about everybody, and I don't think that we see reversals in autoimmune symptoms, with that. I mean, it's an improvement, but I don't think, the results that we're looking for and what we're discussing here, you need higher doses than that.
Well, I think
Can I ask Dr. Burgess one question? What treatment did you try? Homeopathy? And what are the treatment for that vitiligo patient? Because I have one and I am really interested besides vitamin D because we are trying, not as high, but it would be interesting to know.
I tell you what, if I could get your email through Bill.
Okay.
All right. If you say please.
Please.
Okay.
And I would love to share with you on that because you probably have theories on toxins causing it, right?
Yeah. So,
okay. Yes, we can talk.
Okay, thank you.
Thank you.
All right. Here's the money question. Is it
Money.
really worth pushing the doses and the risk to get a reprieve in symptoms? That's $1 million question.
Since we're a research group, our little committee, everything we talk about revolves around safety. So my question is how safe, and you kept repeating tonight how you do the safety checks and all, but if it's safe, why not?
Well, you have to remember that you're not only pushing vitamin D, increase fluid intake, take the other supplements, calcium limitation, dietary restrictions. So this is really going to be putting somebody, it's almost like cancer.
More than that is a kidney damage, nephrocalcinosis, which is many times irreversible.
Right. So
yeah.
I think that is the most important thing that we have to remember. It is we can deal with the parathyroid, we can deal with everything, but sometimes ultrasound will not show you early changes, and by the time it shows there's calcinosis or something, and I'm not too sure how much you are going to be able to reverse it.
Right. Well,
So,
try not to get into trouble in the first place.
yeah, Jeff Bowles has a book on high doses of vitamin D, and he's urging now that you use magnesium in these high doses. Magnesium should be 1,000 to 1,500 elemental magnesium. And in addition to the things you listed there, he also has put in boron and B5 in the things that you would need with the high doses of vitamin D.
Okay.
The boron is to prevent the osteoporosis?
I don't know. I'll have to ask him.
So we use boron to lower sex hormone binding globulin, to get an increase in testosterone.
Yeah, okay.
So how does sunlight exposure affect it? I wouldn't think sunlight exposure would matter all that much. I mean, we have patients that live in Hawaii that have that are outside all the time and have vitamin D levels in the 20s and 30s. So I wouldn't expect that, that they're in, sunlight all the time. I wouldn't expect it. And again, I don't have anything to go on but I get just experience. But I wouldn't think it would affect it that much. I don't know if anybody else has anything to add to that.
So now you're going to add that to the limitation too. Do not expose yourself to So you're avoiding
Well,
calcium diets and then
yeah,
avoid sunlight exposure.
we've been telling everybody that if you use sunscreen, you're not going to get absorb enough vitamin D. Now we're going to tell them to put the sunscreen back on.
Yeah. So there's more tasks to
May,
do
may I
than just
add
the
something?
protocols.
Sure.
Dr. George Fletches on YouTube has a video on the use of boron for osteopenia, osteoporosis, and using in this country it only used 1 to 3 milligrams, but in Israel they get 10 to 20 milligrams a day of boron, and in Turkey they get 20 to 30 milligrams a day. Toxicity is seen in pregnant women at 1,600 milligrams of boron. So it's very useful, and there's even a sin porter to pull calcium into the bones from boron. And so a company called that makes Boro tabs, 30 milligrams a day. When Dr. Fletches took the Boro tabs for a number of years, he had the DEXA scan at age 65. He looked like a 40-year-old, 35-year-old in that DEXA scan. So that it's very useful to use higher doses of boron.
So, and again, remember, boron will raise testosterone levels. Adequate testosterone levels will increase bone density. So, it'll, one hand.
Well, you're getting multiple effects.
Yeah.
Anyway, it's a great lecture. He's kind of soft spoken, so you may need to turn up the volume, but it's an excellent lecture. George, Jorge, Fletches, Flecchas.
George, what is it?
George Fletches, Jorge, then Flecchas. And it's on boron and osteopenia or osteoporosis.
Okay.
Just wanted to throw that out to you guys.
Great. Yeah, we'll look them up.
And what pharmacy did he use for boron?
Hakala Research.
Ocala?
Hakala, Hakala.
Hakala.
We get ours from Life Extension. I don't.
Well, they have Boro tabs that are 20 or 30 milligrams.
Okay. Yeah.
And not 1 or 2 or 3.
Yeah. Those are 3. And we've used up to 12 milligrams, to lower sex hormone binding globulin. And it actually works quite nicely. On average, we can get a decrease of about 50 to 60% in about 3 to 5 months.
Can I ask you a question, Dr. Clearfield? Why do people develop high levels of SHBG?
Yeah,
I have some patients that have a hard time lowering it.
I wish I knew. I don't know why. I stopped trying to figure it out, and we'll deal with what we have. So
from the great Pam Smith, she explained this. Any metabolic inflammatory condition. So basically, what she's saying, anything could bring it up. So maybe what she's giving us a message is investigate. He has prediabetes, high cholesterol, hypertension.
It's a great idea. Great idea. Pam's one of my heroes.
Yeah, she was at AMMG too.
Thank you.
And she was in Reno a couple of weeks ago that Dr. Nario missed. So
there's that one.
Okay, you got anything online?
Hold on, one more question for you. Safer or alternative form of vitamin D than calciferol, according to Shell? He's asking a question.
They were pretty adamant about using vitamin D3.
Like D2, D2.
Yeah, D3 and the daily dose, not the extended release ones, not the weekly ones.
The reason I brought that up is years ago, I did a Google search on vitamin D as a rodent poison. And I did an AI search, and it can still be used to kill, mice and rats. So that's kind of a negative icing on the cake.
Vitamin D, I mean, we talked about, it'll kill your kidneys, right? It'll send you into cardiac arrhythmias. And it'll cause seizures.
It requires a lot of supervision and balancing and whatever is involved.
Yeah, I mean, I don't think this is Joe Smith who comes in with a slightly low thyroid and a TPO of 15, and a couple of symptoms or no symptoms. I don't think this is for that for this person, but we have patients that have, severe MS symptoms, and they've pretty much given up. We have, again, we have,
Horrible.
thyroid, they have the thyroid resistant, thyroid antibodies. And we even have a hard time, controlling them. I think we do much better than pretty much anybody else in town, with our protocols.
Is there
But
an epigenetic implication?
problem. Oh yeah,
Yeah.
absolutely. Yeah. Yeah. Okay. Some of the patients, they don't want to hear it, but if any type of thyroid, in fact, probably everybody, nobody should be eating gluten ever. I think that's the bottom line there. But
Even matzo balls.
even matzo balls, yeah, you're gonna have to find gluten-free matzo balls, Shell.
I'm sure they exist, or they can be made up.
Okay. All right.
All
I'm
right.
going to show you this
Some
again. I got to
online.
show you this again.
Dr. Bill,
You get
online.
this cool bag, and you get a energy plug with our logo on it.
Dr.
So,
Bill, we have an online question.
okay, go ahead.
So you mentioned about heart problems, especially electrical abnormalities with the therapy. What about calcification of arteries? Has there been any, I guess, studies that were
Again,
showing?
I don't think they've had long-term studies on this from, high doses of vitamin D. Usually it's, vitamin D is acute toxicity is the usual thing. So I don't know that I mean, you might have, a lot of patients with calcified, coronary arteries, and the vitamin D, that's inflamed. The inflammatory component of it will set it off. I mean, I can see that as a scenario.
And I think as part of your protocol also, you place
Right.
K2. So as part of K2 D3 therapy, you definitely want that K2 to divert
Right.
the calcium out of the
Yeah.
arteries,
And
but
and I can
instead
think of a
put it
couple of
above.
other things that we do pretty routinely here, that could be part of that protocol also, to enhance things, because we measure hormones and we measure, the inflammatory markers and all the stuff that we do. So, we can certainly come up with, our own sort of version of this. But this is the Coimbra protocol. I thought it was really fascinating. I have a half a dozen patients, just off the top of my head, that I might approach with them after I finish my informed consent.
Tell us about
And
it.
if we do it, I will. If you're interested, we'll report back and tell you how it is. And if you see me on the front page of the New York Times as the quack of the year, then you'll know it didn't go so well. That's all.
Well, I got reported by an endocrinologist in the VA for me just giving his patient testosterone. What more if he sees on his chart 50,000, 100,000, 300,000 vitamin D international units, me giving it to him. So I know what the ending of that would be.
Well, what did Dr. Cerna ask? Is it really worth, where's that question?
Well, if you're going to be viewed as by your conventional colleagues, man, they're going to scratch their heads for sure. But if it's us, sure, we understand.
So
So,
I have a question about your experience with people with autoimmune diseases,
Mhm.
because you said that you might be asking some of your patients if they might be interested in this protocol.
Right.
Do you find that people with autoimmune, all right, so what I find is that people with autoimmune diseases tend to be self-sabotaging,
Um,
their care, and they're highly reluctant to actually do something that can cure them.
um, well, maybe the newly diagnosed autoimmune people, but the ones who've had it for 20, 30 years and they're just sick of it, and they're finally ready to listen. Those are the ones that we kind of get through to. So, you kind of, I guess, pick and choose, who you're going to, who you're going to, approach, especially something like this too. Um,
Right.
and if there's any hint of, that they're going to be reluctant to, well, we just can't do it. Okay.
Because it puts me at risk too. If you do something that's not fully conventional and you're trying to help them and they
Oh,
are not really interested, they could,
we passed fully conventional a long time ago.
yeah,
So,
yeah. I honestly don't find any difference between the newly diagnosed and the long-term ones. I
um,
honestly feel
I
like
think
the
the ones
ones that,
that are long term and they've sort of accepted this is the way it's going to be and they're never going to get any better. And then we bring them some modalities and they do feel, somewhat better, even if they're not cured per se. And I never tell anybody that I can get rid of it, even the ones who show up with I like when I see the H. pylori guy, I know in the back of my mind that, maybe this will be, one of the ones that it'll go away. And let me tell you, when that happens, I mean, that is a
mm,
miracle, and you are, the hero of a lifetime.
yeah,
I've
but I almost like don't want
got
anybody to
about,
bring up the root
on
cause.
average, 1 to 2 patients a year with that in that situation. So, it's not often, but it does happen every once in a while. And again, I don't. It's only been men. I don't know why. So because
Men who succeed and actually
yeah, uh,
cured.
yeah, I don't know why because I do the same thing. I do what we've been taught, and I don't see what the difference should be. But that's
Well, we're more complicated than you are. I mean,
yeah,
we have one morning
well,
part.
there's that. Well, there's that.
I mean, that's why. Well,
Steve
to
Gall asked about vitiligo homeopathic information. So, Dr. Nario, I don't know if that's you or if Dr. Gerber's on or somebody else.
I think Dr. Burgess is going to give out
Dr.
something
Burgess.
for
Okay.
vitiligo.
All right. All right.
But I think I want to double down
I
on
don't
Dr.
have any
Stern.
hot one.
huh? You don't have any?
No.
I don't have a hot one for vitiligo.
Okay. All right.
Well, I just want to double down on Dr. Cernas because I know that what she's talking about, that a patient does not only have autoimmune disease, they have other comorbidities as well, hypertension, high cholesterol. So this kind of like, I think as I teach patients to fix those other problems, I
Yeah.
kind of see autoimmune diseases also going down at the same time. So yeah, I think there's some truth behind what she's saying.
Yeah.
I
There
find
were,
the people that come in to be treated for it, like they can get really mad about what I want them to do. Like
well,
they come in and pretend that they want to do whatever it takes to get well, but then I don't know, they seem to self-sabotage and
yeah, yeah, yeah. I
really
mean that
angry at
happens all the
me.
time. We saw them 3 months ago. Um, uh, we saw them, a year ago, and they were feeling terrible. Then they felt better, and now they don't feel so good again. And we look at the labs, and the labs are maybe not back to the baseline, but they've all slipped back. And then I go through we recommended this. No, I didn't do this. No, I didn't do this. I said, okay, I see where we're going here.
Yeah,
That happens. Unless you hire somebody to follow them around and make them do what's recommended. I don't know what you can do about it. I mean, they're unless they're little kids, they're adults, and I tell them,
okay,
look, I'm sure this has happened to all of us. They come in and they start apologize. I'm sorry I didn't do this. I'm sorry I didn't. I said, don't apologize to me. Apologize to yourself. I'm just the
right,
messenger.
right. I just feel that it's the autoimmune people that seem to stand out with me.
Hmm.
Being, I don't know, just it becomes a frustration for me because I'm trying to help them and then they, I don't know, turn on me at some point and
Yeah, that happens.
A
Or they go away. You don't see them for a year or two, and then they come back. And I said, well, okay, you cheated on me, but now you're back. So let's take it from there.
A
Um,
rabid fox will bite you, and an old Doberman will as well. If the brain has inflammation and
exactly.
degeneration, they tend to be a little nasty. And
Yeah,
yeah,
that's what I think's going on.
yeah.
so
So maybe we can just. And by the way, since we brought up the vitiligo, the homeopathy, the acupuncture, um, and we brought up the toxicity as well, it's a three-way street. So one of the ways I use acupuncture, and we're going to be talking about this at the meeting in Reno, it's not just the homeopathy, but I use homeopathy as an activation of an acupuncture point. This is new stuff. So and that way we use very little acupuncture. I mean, very little homeopathics. So it's cheap, safe, easy, fast. So we could probably within 1 or 2 minutes hit the points that are necessary to be involved with this. And I think we ought to have a meeting, talk about it more. Dr. Nario, Bill, anybody interested?
okay, yeah, yeah. I mean, I've been
Hmm.
mentioned. I've been an acupuncturist since 1990, 91, and when I started using acupuncture points for all my injection sites, the success rate became much greater. So we
Yeah.
do cosmetics. I mean, I do Botox. I use acupuncture points in the face. I do it completely different than you're taught in the schools. We use about a third less of the product. I never
Yep.
say never, but we may get a little drop of blood. We never get bleeding. We never get hematomas. We never get eye droops. We never get any of those complications. We
There you
use
go.
fillers when we use the acupuncture points for our entry points. We don't get blood vessel occlusions. We use much less product and get as good results as anybody else, and we use a third to a half less product, so you can use the same amount of product and do twice as much.
There you go.
For injections, shoulders, knees, backs, again, acupuncture points are golden for knowing where the acupuncture points are and using them as your entry point. Whoever figured this out, remember, the Chinese, when they figured this out 3,000 years ago, anatomy was taboo in their culture. They didn't do anatomy dissections. So how the hell they all figured it out over time is is a mystery to me. But those acupuncture points are they are like sacred. I mean, they are just great. And then you can do combinations of them also. If you're interested, there's a Dr. Tan's, Dr. Gerber, you know about these, the Dr. Tan's magical points. I think there's 12 points.
No, but I'd love to spend a couple of minutes on the conference when we can.
I got aced out. I'm not speaking at all unless we get a dropout here because we got too many. I was going to speak on developments in my career over the years from the 70s and every decade, 3 or 4 modalities that I've changed over the years up until yesterday. So I'm talking about vitamin, 100,000 units of vitamin D. So
apparently Dr. Andrews is coming.
yes, we got a report.
An email from
we got a report that he had died 2 years ago. And I at first it didn't register me. I started looking it up, and then I said, "Wait a minute! He sent us a slideshow like 2 weeks before. It came from him."
Must have been another Bill Andrews, and Dr. Nario, Dr. Ibarra sent me I think a little brief review of her talk, and I think you're going to be introducing her. You probably have that already.
Yes, she's going to be moved, so you're going to get. She's going to be on Thursday instead.
Yeah, I see that. I just want to make sure that you had the review.
Yeah. Right, and we got Dr. Devlin 2 hours there for you too.
Yep.
I see that. Thank you, guys. Appreciate it.
Hey, Dr. Gerber, you say jump, we say how high. You know that.
Oh yeah.
And I would have moved Dr. Swadan out of that to a different spot, but that was the only time she had for us. So,
all right. Well, bless her. We'll give her a good run.
Okay. All right. So again, everybody, Thursday morning, 8 a.m. If you're online, you should be getting. I don't know if it went out tonight. You should be getting the link. It'll be there by tomorrow at the latest. I think it went out already tonight. You may know if it hasn't. Somebody let me know. You'll be getting the link for the Zoom link. It'll be different every day, though. We did that deliberately, so you're going to be getting a different link every day. And the reason we did that is I don't know. Kevin had a reason for it. I don't remember what the reason was, but because I mean I've been on these, and of course they gave you one link for the whole time, but he wanted it for a different date. He did have a reason for that. So again, if you're in Reno tomorrow night at 6:30, we're going to be at Brick's Restaurant. I need to make a reservation for you. And again, Dr. Cerna, Dr. Tano, you're in. Dr. Nario, you're in also. Dr. Halasso is going to be there, and our good friend Joel is coming to town for the conference too, and Joel will be there also. So we'll have our own little soiree. We'll be listening to oral testosterone undecanoate. Which we were all taught don't never use oral testosterones because they cause liver cancers or something like that. So, but this is the new era. So there's 3 brand name products that have come out in the last 3 to 4 years. Apparently they're absorbed through the lymph system. They don't go through the liver. So
Interesting.
That's it.
Thanks for all the hard work, guys.
Okay, thank you so much. I got a lot of stuff to do yet tonight because I got a checklist as long as your arm, and I hope this was, at least interesting. If we never pay attention to it again, that's okay. But when I first heard about it, I just, sat up straight and I took notes and I listened, and then I've been doing, my own research on it, and I thought it was pretty impressive. So
I assume it's still scheduled, right? Because it's
what's that?
testosterone. I assume it's still scheduled, right?
What? Oh,
It's
testosterone?
testosterone, right? I mean,
Right.
it's not a precursor or anything.
No, no, no. No, this is a scheduled drug.
Okay.
This is the real deal. Yeah. This is
Okay.
not it's not a supplement. It's a
Okay.
regular prescription, class 3, and whatever and all
Yeah.
that baloney.
You just can't kiss anybody all day, right?
No,
Uh, oh my
they
God.
also rule it as a class 2. So if you're a physician trying to cover your ass, think of same level as Oxycontin.
Yeah. So, okay. Heather, are you still here? So next week, Heather Hallis and we're going to be
I
here.
am here. Dr. Robert
Okay. So
Salea will be here as well.
can you give us a 1 minute, overview for next week?
Well, it's going to be pretty exciting because he's going to talk about some methods that are used with nutrients that are kind of groundbreaking. And also he may be talking about magnetic. Well, I want him to tell you because he's going to say it in a way that is okay. Like, I don't want to say anything that's not okay for, people that aren't doctors to say. So he'll tell you, but it's going to be a really great hour, maybe 2 hours of information that he has put together. And it's just about different methods and different uses of nutrients and ways of getting them to be accelerated and more absorbed into the body. And he has all of the scientific talk about it.
And he being
Dr. Robert Salea.
Okay, great.
Yeah, from Mexico.
Okay, so that's next week.
It is next week. Thank you.
Next week, same time, same station. By
You
then,
betcha.
those of you who weren't online and weren't in Reno will be kicking yourself. And then those of you who are going to A4M, we're going to be saying, I should have gone to Reno instead. Because here you can learn something. It's too crazy there.
Reno's better than Vegas too.
And it's a little quieter than Vegas, yeah. So, okay. So I can't wait to see all of you that are going to be here. And it should be a great show.
Bill,
So-
how can we get it on the online? Unfortunately, I cannot come to Reno.
Okay. I'm gonna give you the website, Congress of.
Can you send it to me or?
I can.
Okay, thank you.
congressofmedicalexcellence.com. I'll send it to you.
Thank
That's the website, and you just click on register. It'll be on the front homepage. It'll be all the way over on the right.
Okay.
And let me show it to you here. And yeah, that's.
You're not going to show them the 2 bars on the upper right-hand corner, right?
Oh yeah, we're by the way, did I mention this that we're having a contest for who amongst the participants questionnaires ask the most ridiculous question that we had to waste time on, and so far the winner is a certain physician who said he couldn't navigate the website on his telephone because there was no way to get to the agenda. He couldn't see the agenda. He couldn't see anything. And so I pulled it right up. And he said, well, now what do I do? And he said, well, there's 2 bars on the right there. You touch the bars and the agenda comes up. He goes, well, how am I supposed to know that? I said, that's a universal thing. Every URL that's done on a I'm trying to get the website for the
Hey, Bill, something that might be a little bit important here is that if you go to the register on the Congress of Medical Excellence, and at least in West Virginia, and if you click on the info at Congress of Medical Excellence.com. It does not open. So some people may be trying to communicate by email and cannot get through to this site.
All right, I'll look at that. So here's the homepage on the computer. Hit register now over here, and whatever category we see we got 9 million categories here. And
Hey.
Yeah.
Go where it says at the bottom, Bill, information, info there. Just click on that. See if it opens for you.
Okay. Google Chrome.
That's important if people can't reach us. And I'm not on Google Chrome either, but that's what's popping up. So it may be on your end that people cannot communicate. So we might fix it. I already told Kevin.
I'll see what we can do. The nice thing about this is in 2 days it won't matter. So okay. So,
yeah, we even have extraterrestrials special.
See, we have ET here.
We got everybody on this show.
Yeah. So there's lots of categories. Pick one. We're not too picky anymore. If you're in practice, don't send us student rate. and we have a rate for internet for outside the US and Canada. Because if you'll remember, we had Lisa Tamati on, and she's got some folks in Australia and New Zealand. And they're not CME folks, so we gave them a good price, and then we have the Philippine people too. So, but we need your help. We need you to support us here. We've had a little dry spell. We've been running these Tuesday night conferences every Tuesday since 2020. And we don't charge for them. There is some costs, not including wear and tear on me. So we don't charge for them. The CME credits, if you buy them, that goes to the CME people. We don't see a dime of that. That doesn't come to us. We've had a dry spell since the AOA kicked us out as far as raising funds. So I'm hoping we're going to break even. We may have overfed you folks, but it should be a great time. So okay.
Thank you.
Comments, questions? If you got any complaints, put it into ChatGPT, tell them to make it humorous, and then send it to me. Okay?
Or just send it to me if you don't want to do that.
What's that?
Or just send it to me. I'll filter it for you.
Send it to that info that doesn't work. And we'll get right on it for you.
You will receive it.
Yeah, we'll get right on it. Send it to that info. So, all right, I'll look into that. All right, everybody. Anybody else? Any comments, questions?
Thank you. Please send me the link if you can. I'll try to get on there.
The link for who?
Yeah, for the conference. I will try.
Who am I talking to?
Heather.
Heather. Okay.
Okay. I'll do my best.
I thought you registered. No?
I wasn't able to yet.
Okay. All right. I'll send it to you, and I'll send it to Dr. Patel. Anybody else? That's why we have the website. It makes it easy. Okay. All right.
Thank you.
Everybody. Thank you so much.
Right.
We will see you next week, same time, same station, and make it to Reno now, right now. Go right there, right now. congressofmedicalexcellence.com and register right now because we're almost done. Wait, there's 2 more here.
Oh, I already answered myself.
Is it slides to get to these webinars? We got the videos.
I found it on the Otter site.
AOSRD.org. The Otter site, yeah.
Otter.
You can get it on that.
Yeah, I found them.
Okay. All right. I don't even maintain that. I just have that on. It just does it himself.
It's very nice to have.
Okay. All right, everybody. Thank you so much. Thanks, Shell, for everything. Are you going to be on, Shell? Are you sleeping? It looks like he's sleeping there. We going to see you this weekend at all? Online?
I need my press pass.
Okay. Let me know.
We'll talk about that.
Yeah, let me know. Okay.
Okay. Yeah.
All right.
No. It's going to be good. This was a great talk, by the way.
Okay. I'm glad you liked it. So,
what's not to like? It's always great.
Okay.
He gets a
Consistent.
free ticket for that.
Tell them at A4M. They don't.
He gets a,
They have
he gets
no
a free
use for
pass.
you.
I'll work on them.
Yeah. When there was the gal who used to run it a couple of years ago. I used to take Botox and do Botox on her, and she would put me in the program. Since she left, nothing.
Well, it got political because the people that own the organization, they're
Yeah.
more in charge of who speaks now.
Well, it's like, didn't we talk about something about political there? And so I said, I don't care about that. You know, you mentioned something else. I don't care about, Honduras, Roatan, right? No, we don't care about that. We just want the sunshine. You fight, you guys fight amongst yourselves. Leave us out of it.
No, no. I mean, I really think you should get more credit.
Okay, yeah, my father would say that and 15 cents will get you a cup of coffee. He's dating himself, right? So, all right, everybody. I got a lot of stuff to do here to get ready for Thursday morning. So, I'm gonna. You guys can stay on if you want, but I got to get going here. So, okay.
Thanks, Dr. Bell.
Thank you all.
See you tomorrow.
Okay, see you tomorrow.